Chapter 10, Disorders of Nutritional Status. So our ability to maintain homeostasis is related to our ability to take in calories and use them. It's a simple formula: calories in is equal to calories used and plus calories stored. The caloric intake is controlled by appetite, and the hunger and satiety centers in the hypothalamus are what regulate that. Calorie use is controlled by our metabolic rate, which has to do with our activity levels and our thyroid hormones. And calories are stored in adipose tissue, white adipose tissue and brown adipose tissue. You don't need to know the difference there. This caloric cycle is regulated by both short-term mechanisms and intermediate and long-term mechanisms. The short-term regulation is related to the process of eating. Basically, the GI tract secretes some hormones. While we're eating, we chew it, we taste it, we swallow it. The stomach stretches to accommodate the increased load, and all of that signals the hypothalamus that we are full and eating should stop, or at least that's the way it's supposed to work. The intermediate and long-term regulation has to do with our stored nutrients. A lot of energy is stored in fat cells. An increase in blood sugar, increased keto acids in the blood, and leptin also help us help the hypothalamus feel full and signal to us that we should stop eating. Or at least in theory, that's the way it works. As part of our job as nurses, we will be assessing people's nutritional status. We usually do that in relation to body mass index. Please memorize the body mass index calculation because you will be using this to assist you in your assessment throughout nursing school. There are other assessments of nutritional status. We use body weight as a relative measure. We match this up with desirable weight based on your build and height and some normative ranges. But when we're talking about using weight as a marker for, say, medication delivery, we will use body mass index or BMI. There are also mechanisms to determine percentage of body fat. We don't tend to use those, but dietitians will. The biggest takeaway from this is upper body versus lower body obesity, or apple versus pear-shaped. We do understand that apple-shaped or upper body obesity is associated with metabolic syndrome, particularly because of the intra-abdominal fat distribution that takes place. We know that obesity has a familial link, but we're not really sure if this is a genetic link or an environmental link. The latest studies on gut health are telling us that the bacterial makeup of the gut may play a role in why some people are more susceptible to obesity than others. What we do know about obesity is that it increases the risk for a variety of different disease processes. Think about the fact that fatty tissue actually acts as an endocrine organ by regulating leptin and resistin and increasing or decreasing insulin sensitivity. And we know that high levels of fatty tissue are negatively associated with the inflammatory process because of the production of C-reactive proteins in high levels. Diseases that are associated with obesity include diabetes, hypertension, sleep apnea, gallstones, but we know that obesity is linked to a multitude of disease processes. This picture gives us a high-level idea of the clinical manifestations of obesity that may take place throughout the body. When it comes to malnutrition, we don't usually study malnutrition because we live in a society of abundance, and we mainly associate these kinds of malnutrition with children or with extreme levels of poverty. In general, malnutrition results in the loss of fat storage, which is our stored energy, and a wasting of muscle mass. The different kinds of malnutrition can be a result of too few calories and too little protein, or just too little protein in the diet. You will not have to distinguish between these two concepts for testing purposes. What you will see more frequently in your daily travels throughout the hospital will be the normal changes of aging related to nutrition and changes that are related to malnutrition. As the adult ages and the body ages, there are alterations to the taste buds, not being able to see as well, smell as well, taste as well comes with aging. We also know that adults over the age of 65 suffer from dehydration and have a reduced thirst mechanism. We also have difficulties as we age because of the reduced gastric acid production in breaking down foods into the required elements to be able to use by the body. And we know that as we age, we need more vitamin D, vitamin B6, and calcium to maintain the homeostasis of the body so that the breakdown does not exceed the maintenance. We do know that malnutrition, that our patients are have the potential for malnutrition entering the hospital, or if they are in the hospital for long periods of time, that we can actually cause malnutrition. We know that certain disease processes such as dementia, delirium, and depression contribute to poor eating. We know that the economic status of the elderly highly influences their ability to eat and what they eat. Therefore, when we have patients that come into the hospital, we screen them for serum albumin, and if these results are below average, we need to do something to improve the caloric intake of these patients, or the disease processes that we're treating them for will take longer to resolve because of the malnutrition state. So in my day, a dietitian was rarely called in on a case. In today's hospital setting, the dietitian, this albumin screen, it takes place on the majority of the patients that you're taking care of, and the dietitian is present from the beginning in order to facilitate a faster recovery and healing journey for the patient. Other diseases related to eating are considered psychiatric disorders. Anorexia, the refusal to maintain minimally normal body weight, which would be 85% of weight expected for that height. Bulimia, which is a purging activity, which can be either actual purging, making yourself throw up, or purging in other ways, like using laxatives. And then we have binge eating, where large quantities of food are eaten in small time frames. And think of our gastric bypass surgery patients as falling into this category. We know that the risk factors for these psychological or psychiatric diseases present themselves most frequently in females during the adolescent years, but can also be a result of what athletic can also be a result of being an athlete and prescribing to a set way of eating for your particular sport. Think of ballet dancers, gymnasts, runners, swimmers. Each athletic area has a way of eating that comes along with the sport, and can sometimes contribute to these psychologic disorders. We do not generally see people with eating disorders come into the hospital to be treated for the eating disorder, but we do see these patients present in life-threatening situations, generally related to heart failure or lethal dysrhythmias because of fluid and electrolyte imbalances. At the time that we see them in the hospital, and we note their status of being below normal body weight, we then can, after treating the underlying condition that brought them into the hospital, refer them to outpatient services.